Great pleasure to introduce Dr. Andrew Olson today. He's an associate professor of medicine and pediatrics here at the University of Minnesota. He practices hospital medicine and pediatrics. Many of you have probably seen him up on the 6th floor taking care of patients at our hospital. He also serves as the section head of hospital med in the Department of Medicine, and he helps to lead a new initiative, the medical school's Medical Education Outcomes Center. His academic work focuses on the development of expertise in clinical reasoning and diagnostic safety and quality, as well as medical education research. This year, he serves as one of the directors of mHealth Fairview's COVID cohort hospitals, Bethesda and St. Joseph's Hospital. I'm really looking forward to hearing about his journey in taking care of patients on the adult side, which we don't often hear as much about, but I think often informs our care. So thanks so much for being here, Dr. Olson.
Great, thanks so much, Dr. Borman-Shope and Dr. Neglia. It's a real honor to be here and to talk a little bit about where we've been and where we're going. This has been quite the year, and it's not ending anytime soon. And I was talking with Emily about where we go, what would be good here. And I think talking about taking a moment to step back and say, where have we been this year? What have we learned? I'm going to share a little bit, a few personal nuggets of things I've learned in this experience, not because I've done anything special, but because I think it gives us all a chance to reflect on our personal journeys going through this. I'm going to talk mostly about adult medicine today. I'm not going to give an update on pediatrics, MISFI, or anything, because I think sometimes in peds, we see one part of this. There's that famed picture of the elephant where people see different parts of it. And I wanted to give everybody a chance to get understand some of the context outside our department and what's happening. The only disclosure I have is there's an awful lot of unknowns here. And the other is that most of the medications I talk about are actually off-label here because this is a new disease. So as we begin, I'm an optimist. Those of you who know me know that I'm a pretty optimistic person. And this year has tested us all. It's tested us all because this virus came and we felt powerless. First patients rolled into the hospital. We didn't know what to do. George Floyd was murdered. It felt like the world was falling apart. There's this milieu of politics. And I ran across this quote from an artist from my hometown in northeastern Iowa, that anyone can slay a dragon, she told me, but try waking up every morning and loving the world all over again. That's what it takes to be a real hero. There's a ton of heroes out there because those are the people who are still loving this world and walking through it every day, because this is a tough time. That said, this is a quote that keeps me going every morning, and I wake up and try to love the world. And so I'm going to walk through the last 7, 8, 9 months of the year, intersperse it with a little bit of what my journey has been in helping to get to lead some of this and talking about some of the medicine as well. My COVID story starts in Florida. Actually, my kids go to Roseville School, so we have a really early spring break. And we had a really odd plane flight. It was pretty empty going to Florida to spend some time. And this was the day that we were supposed to go to spring training baseball game. And the day before, spring training was all canceled. And so my family went for a bike ride on Sanibel Island. And in vacation, I was serving as the interim head of hospital medicine. Didn't really know what that meant. My phone and my email really blew up. And I was spending time in the evenings and the early mornings on calls, realizing that this thing was coming and we had to have a response real quick. The other context there, of course, is that our hospitals tend to run pretty full across our system with special pain points around ICU and intermediate care. And how do we care for a ton of patients that might come, a wave of patients? But there were also so many unknowns. And I was looking at my kids and reading stuff coming out of New York and starting to come out of New York, coming out of China, coming out of Italy. And sitting watching my beautiful kids on the beach and thinking, what's coming? What is this thing and how do we deal with it? And so then the world started to change. We came home on, again, a pretty empty flight. By then, a week later, the airport was a ghost town. New York City here shown is shut down. There's a few people sitting on benches, but cities are in lockdown. Our kids didn't go back to school just like your kids. Everybody was at home. And we as a health system had to say, what the heck do we do with these patients? We need to provide incredibly high quality, evidence-based patient care. By the way, there's no evidence base for this disease. We can maybe learn from MERS. We can maybe learn from other coronaviruses. We can maybe learn from caring for the patients with the acute respiratory distress syndrome. But there was so much to learn and so much unknown. But the other feeling that was purveying at this time was fear. Fear because there was so much unknown and we didn't know if it could be safe to care for these patients. What is it like to care for patients? How infectious is this thing? And by the way, there's not enough N95 masks. None of us ever imagined that we were in a time where there was green, yellow, and red charts getting emailed to us every day about how much PPE we have. But that's where we found ourselves. We found ourselves learning about supply chains. We found ourselves learning about the difference between an 1860 and an 1870 N95 mask. All of us realizing that all those years we had grumbled about going to fit testing. Oh my gosh, I love the fit testing people. And that's when good old-fashioned Minnesota ingenuity came into play. Our system looked around and said, where do we have capacity? And where can we provide incredible care? And they identified Bethesda Hospital. Bethesda Hospital has a long and storied history as a Lutheran hospital in St. Paul. Has incredible stories for those of us who spent time there walking through and realizing there's so many different things that have happened there over the years, but its most recent iteration has been as a long-term acute care hospital, caring for patients who need ongoing acute medical care as they rehabilitate from things like a stroke, motor vehicle accidents. They're there for months. There's lots of reasons that the long-term acute care hospital census has changed in recent years, and there's an opportunity to repurpose Bethesda once again into a COVID hospital. Decision was made, and then we said, okay, what do we need to do? Well, we need to make negative airflow rooms. They made 3 ICUs with negative airflow rooms in a weekend. That was pretty cool. We learned a lot about setting up a hospital. We were getting ready to start this thing, and we realized the pagers were on a different frequency than other places in our system. We had to figure out how the heck do we get the pagers to work? By the way, who's on a code team? Every hospital I've ever walked into, and those of us in pediatrics who were there a little bit when Masonic opened on currently on the West Bank, I think walked through a little bit of this. But how do you build a code team? By the way, there's all this stuff that just didn't exist before that we had to put into place. Who staffs this thing? And I think for as long as I live, I will be incredibly grateful for this time that we've had at Bethesda and St. Joe's at the peak, and now again St. Joe's. I'll talk about that a little later. Because people who ran to this fire, who signed up to work here, including some people in our own department, some of our peds intensivists have been over there, our med peds hospitalists have been over there. There's no pre-existing culture except people who want to help and do the right thing. And so the decision was made to turn Bethesda into our COVID cohort site, which really allowed us to do 3 things and continues to allow us to do 3 things. First, number 1 is provide really high level, high quality, evidence-based care. Second is, along with that evidence-based care, continue to do incredible amounts of research. We have a moral obligation as an academic health system to identify ways to make care better for this novel disease. It's our job. We can't just take care of these patients. We have to study it. Thirdly, it allows us as well to keep other parts of the health system going. As we know, elective surgeries are important not only for patients, but for health systems as well. And all of those things contextually also make it safer for our staff. There's no mystery at our COVID cohort sites. We know who has COVID. and there's no reason ever to let our guard down there. This is my favorite quote from Kennedy, and I've been spending a lot of time thinking about that. We chose to go to the moon in this decade, although if you hear the Kennedy quote, he says decade, and do all the other things, not because they're easy, but because they are hard. This is hard work at baseline. I don't think medicine was easy a year ago. I don't think it was easy 5 years ago. It's not been easy this year. But we do it because it is hard and it is good, and it is to which we are called. And I'm incredibly grateful for that. But I've been thinking a lot about that. And also I'll share hopefully a tiny bit of wisdom at the end as well, about how we balance doing hard things. But then there was so many unknowns. Do we intubate early? Do we intubate late? Do we use high flow? How aerosolizing is high flow nasal cannula oxygen? Is it aerosolizing to suction a patient? How is this thing spread? Is it the door handle? Is it prolonged contact? What is it? What works? Do steroids work? Does remdesivir work? How do I pronounce remdesivir? There's so many unknowns. And that's when we started to realize that we had so much to learn. And we as a system, I think, grew up about 10 years. We started really amazingly well, learned how to work together from our academic and our community partners and start to answer the questions. Who do we test? When do we test? Turning research labs into testing facilities, and then saying, how do we test these patients? How do we test? What does that negative test mean? What does a positive test mean? We got to talk about sensitivity and specificity and strategy and PCR and cycle times, all those things. And I think one of the first medical things I want to talk about is diagnosis of this condition. I think this is one of the most fraught problems, and I think it's fundamental we separate two things. You've probably heard this from our ID colleagues or our infection prevention friends. And those two things are that we have to separate public health and patient care. Testing for public health strategies is very important. There may be a role for things like antigen testing, but testing for, is this patient in front of me, A, infected, or B, are there symptoms that they are having from COVID, from infection with the SARS-CoV-2 virus? Are those things, is that virus present? As we know, there's a lot of problems with false negative tests, primarily because I'll take you through some of the studies that have done that. But we know the first thing that shows up is positivity of PCR from the nasopharyngeal swab. You can also get it from other respiratory tract specimens. Those of you who've been following your email know that saliva testing is probably pretty good. It tends to stick around in the stool. We don't really know much about what that means. But we learned a couple things early on here. First, there's a lot of false negatives too early in testing. And this PCR stays positive for weeks and weeks and weeks. We've had patients positive in our system for months. There was also a huge push toward antibody testing. But again, what does that mean? What does it mean to have antibodies? What does that mean for immunity? And we're still emerging, and that still continues to emerge. But we realized that the reference standard here for do you have a COVID infection is a PCR test that's imperfect. So one of the things we started early on talking about was, do we do one test? Do we do two tests? Why is that? And we started really to have a chance to delve into some of the emerging evidence that was coming out. And by late spring, early summer, I feel we started to have a pretty good handle on testing. PCR testing is very, very specific. We think it's probably 99% specific. That is, it's unlikely to have false positives. Now, the analytic sensitivity for the test, if you take a known positive and test it if you test a known positive sample, the analytic sensitivity is at least 95%. It's a very good test. But we know that most of the problems actually are probably pre-analytic from collection and other things, such that overall in this study, which was very elegantly done, that had a way that had some assumptions but retested some individuals, showed an overall sensitivity of 82%. We've used the number for most of the calculations in our system about 75% sensitive. That means in 3/4 of the cases that are true positives, you will have a positive PCR, and about 25% of the time you'll have a false negative. I think that that's a conservative estimate. I think the test might be operating a little better than that right now, but important to pay attention to. But then we started to realize, okay, so when do you test people? Do you test people at the setting of an exposure very quickly? Do you wait a few days? And this was a really, really nice paper that was published in Annals of Internal Medicine in May that stratified patients by their pretest probability of disease and looked at from 0 on to 3 weeks about what their positivity, their PCR positivity was. And what we found is you follow those 3 curves, or excuse me, those 4 curves that are stratified by pretest probability or risk of disease. You'll see that days 1, 2, 3, the test really doesn't change your pretest probability at all. And so since the goal of a negative test is to decrease the probability, you'll see that as you go on now to that 5, really peaks around between 5 and 7 days, that's when you have a negative test, that's when that's very helpful in starting to eliminate disease. But we know you can't test too early. So we were learning this. We were starting to identify who might have COVID, who certainly doesn't have COVID, who may have COVID, who does have COVID. And it came time to open Bethesda Hospital. And it was an amazing day up there. The first day the patients were going to come the very last week of March. And we had the opportunity, some of us, to talk to the team that was going to be taking these new patients. We had just figured out like where the ambulance dock was and where the monitor was and what happened when that call light went off. All of this was figured out. And we had to stand up there and say, what do you say to people who it kind of felt like we were at the precipice of something kind of amazing and something really scary? And I felt like I was a little bit in a Disney movie when people talk about bravery, and it's not the absence of fear, but action in the face of fear. And I remember standing up there and saying, it's okay to be scared, be kind, we'll follow the science, we'll be in this together. And people did. This is a picture of the first patient, ambulance, who rolled into Bethesda Hospital at the end of March. And from then on, I think really incredible things started to happen. We started to put clinical trials into place very quickly so that within the first weeks and days of patients being there, we were screening in a really robust way for clinical trials, producing the evidence to say, what do we do for these patients? Investigators from all over, from our basic science colleagues and doing some of the testing work, to our colleagues in infectious diseases studying and saying, how do we treat this with antivirals? Do antivirals work? What can we learn from our experience with Ebola and MERS, other things like that? How do we diagnose this using other modalities like ultrasound? This is a picture of our very own Dr. Ben Trappe walking in to take care of the first patient who showed up at Bethesda. And so much we didn't know, so much. But this allowed us to learn quickly and for our teams to develop an expertise and to do something really amazing, to take people who had never worked together before, put them together, and have something pretty incredible happen where people said, yeah, we're in this together. We're a system. We're going to keep patients moving here and we're going to provide incredibly high value, high quality care. This care is really hard though. These were sick patients, continue to be sick patients. Early on in this pandemic, the first, and I'll talk about demographics in a few minutes, the first patients who got it though were returned travelers, but then very quickly, the substantial burden of disease across our system and across our state was patients in long-term care or other group home settings, patients who often had high risk. And this was really hard work. The stories about patients being alone near the end of their lives and things all stick with us and feeling powerless. We didn't have much to add except just supportive care, which I'll come back to in a moment as well. It also began to change and affect disproportionately with no surprise, given all we know about social determinants of health. Our communities where individuals did not have the opportunity to distance, to stay home, but instead went to work, take public transportation, had pre-existing conditions due to long-standing health inequities. But there's moments of light in this. There was a move in early April to late March, early April, to turn your holiday lights back on. I put my Christmas lights back on, and that made coming home feel a lot better. It felt like there's going to be light again, and it will be good again. And I want to remind everybody that it will be good again. We're going to get through this. It will be good again, but I'm continuing to talk about this journey. We also realized that we had to celebrate things. You have to celebrate when something's so hard. You have to celebrate when patients get better. So our nursing colleagues at Bethesda Hospital, together with Dr. Brian Williams, who leads well-being for our system, made a discharge bell on each unit, that patients get to ring this bell when they leave the hospital. We also play a song that I think will be synonymous with hope and COVID for me, which is Here Comes the Sun from the Beatles. Those of you who've been at Bethesda, hear that song come on, and I hope we all continue to stop. And I will never get sick of that song playing overhead. It's like the newborn baby song played at Masonic. I think what a celebration to celebrate that every one of these lives, these people walking out of this place or going out of this place to their next phase of recovery. We have to celebrate those things. We started to learn a lot of lessons, however, continue to learn a lot of lessons, and this is Easter Sunday. This is at the university on Easter Sunday. And that morning, we got a call from a nursing facility that said, we have essentially dozens of patients that we need to transfer to your hospital, or we need a place for these. Our staff are sick and we have to move these patients. And I sat down. I started making phone calls. I had gotten called about this from our operations center and started to say, what do we do? A few hours later, we had a plan for triaging this and doing mass critical care. Most mass casualty planning is in planning for things like unrest or major traumas. We aren't used to mass critical care planning. How do we do this? It turns out it was something of a false alarm on that Easter Sunday from this nursing facility, and that didn't end up happening. But what an opportunity to think and learn and realize the protocols that we thought we had in place, we needed more of them. We needed different ones. We need to continue to think about things slightly differently. Early April as well, we put some things in to count discharges from the 5 South units. At some point, we were up on we had the 3rd and 4th floors open as well as intensive care units on 3, 5, and 6. Each of them gets to count discharges and celebrating that this is one more person who gets to walk out of this hospital. And even though there's many who don't, to celebrate that people get better. We also started to learn a lot about this disease. COVID not only causes acute respiratory failure, which is the main driver of morbidity and mortality in the adult population, and I'm talking about adults here, knowing that please don't translate to medicine except what I talk about for testing to children. But we learned that there's thrombotic events, pulmonary emboli and other venous thromboembolic events predominantly, but also strokes. And so we pretty quickly learned, though, that doing a stroke code in a hospital where everybody's got COVID is a little tricky. And by the way, we need to transfer patients to be able to get the right MRI and maybe consider advanced endovascular neurological procedures. This picture of Jeff Chipman, who is my dear colleague in surgery who helped lead this effort as well, serving in a similar role to myself, but overseeing critical care. And many other individuals here, trying to figure out how do we practice a stroke code and how do we do this? How do we package these patients safely? How do we do this thing really quickly? When we learned, the one thing I learned about caring for COVID patients is do it in a planful way that helps us, no surprises, walk slowly, take your time, think through things. So we figured out how do we do stroke codes, and sure enough, we had to use that. But knowing that it's different than usual, where you say, okay, we're going to put the patient down on the CT scan, or we're going to get the neurologist to come up, and then we're going to decide whether we give thrombolytics or not. Here, we had to decide, do we transfer the patient to a different hospital? How do we keep everybody at the other hospital safe? The other thing that we have to remember, though, and everybody, whatever your context, children or not, caring for elderly parents or not, whatever your life looks like, it's been disrupted this year. This is my two older daughters, and they were at home. My wife's working full time. She's a clinical researcher. And life was really different. And there was grieving, and there continues to be grieving. Sophia on the left here was missing out on her last days of kindergarten. And I was grieving for that. She was a social butterfly, and I felt like she shouldn't have to miss out on kindergarten. And Noelle, happy as a clam to be home, but I felt like missing out on key aspects of what it's like to be a second grader. We found ourselves, like you, I'm sure, outside. There weren't leaves on the trees, but we savored the state parks, hiking, spending lots of time out there, being resilient, because the hard things have to be balanced with other things that take your mind off it and remind you that life is good. Fresh air never tastes so sweet as after a day when you've been under N95 mask. It also gave me time to decompress and think about this, and realized that as a leader, I was asking people to do things that were really scary, and their lives were being disrupted too. So we started to continue to do this work. This is a picture of the state capitol out Bethesda, and thinking about that, we started to learn that this is not a medical problem alone, but this is in fact a public health problem. We all started to realize there's a role for advocacy in this work. There is a role for thinking about, there's a need for a mask mandate, and thanks to you, those of you who advocated for that work, that we wanted shutdowns, we wanted people to stay home. And the juxtaposition of medicine, public health, and policy, I think never can be separated after this thing. And it is such an apropos juxtaposition of things to stand caring for COVID patients who in their rooms at Bethesda Hospital and look out and see the state capitol and think about how those things need to work together. I think we've been incredibly grateful for being in this state now as we look around as well, but I think looking at the governmental policies that have been made, the partnerships, and following the science. There's an outpouring of the community in this as well, thanking healthcare workers. And there's at Bethesda, there's walking from the parking ramp to the hospital. There's this skyway where school kids, church groups, other faith groups, families sent things to hang up. We support you. Thank you for your bravery. And I think people walked through, and I hope took solace from that, and will continue to do that as we move to St. Joe's, because this work is hard work. And I think, again, medicine is hard work in general. But to know that the community was behind us was pretty incredible. And I hope everyone felt that. And that feeling is still there. Yes, maybe a little bit less on the tip of the tongue, but to know that we are still very supported by the community. People are behind us. I was rounding at Masonic and realized it was free coffee. I'd never gotten free coffee from Caribou when they were giving away coffee to celebrate healthcare workers. And I think some of these moments of generosity and frankly goodness, we have to remember. However, we also began to, and I alluded to this a bit earlier, realize that like all diseases, or nearly all diseases, COVID is not affecting our population in an equal way. COVID is, again, a magnifying glass and maybe becoming, hopefully, a rallying cry for health disparities. We had to do better. We have realized this is showing, again, the excess burden of disease, published from Morbidity and Mortality Weekly Report on JAMA, looking at the excess burden of disease on our communities of color here in the Midwest, especially on our Native American communities. But realizing that this is a disease that is, again, highlighting social determinants of health and our absolute need to do better on this, to identify why this is happening. These disparities exist before patients get to the hospital. They almost certainly exist in the hospital, and they will persist, and the health outcomes will be different. We have to stop that. We have to do better. And that was juxtaposed the height of our pandemic, week of Memorial Day, telling people not to get together with the murder of George Floyd. This felt, I think, to all of us kind of overwhelming, and for our healthcare workers and patients of color, doubly so, superimposed on a chronic pandemic that's been around all too long of racism. This is the rally at the state capitol for the White Coats for Black Lives that was led by some of our students. They're incredibly grateful. And walking back after this to go to Bethesda to allocate remdesivir felt like a really strange and almost helpless time of these things, this pandemic of racism and this pandemic of COVID working together to just make everything really overwhelming and sad. But yet people were not helpless, and people did things like this, and I continue to be really proud of the slow changes we're starting to make and the people we're putting in positions to center and start to say, how do we make this better? Hospitalization continues to rise, and we continue to have patients leave, and we now have a board up at the front of Bethesda counting the number of discharges, and we're now between 700 and 800 patients in the last couple of weeks that we've been there. However, the epidemiology of this thing now is, if you look at our curve in Minnesota, this is from last week, continues to really climb significantly. Hospitalizations are up, cases are up. Are we in the third wave? Is this just all the same wave? It's unclear. Knowing that around us in Wisconsin, the Dakotas, it's pretty bad right now, and it will continue to get worse. But yet, I am grateful that it's happening now rather than this spring, because we've learned so much. We've learned how to keep our healthcare workers safe. We've learned that we were very worried. We said you have to plan for 30 to 50% of your healthcare workforce being out. That's not what we've seen. We've seen that with PPE, even the PPE conservation strategies that we have, it works. Our healthcare provider positivity rate acquired in healthcare is quite low. It happens, and that's unfortunate. It's a tragedy every time, yet it is not a huge number of people who have that happen. Certainly it does, but we need to celebrate that it doesn't and realize that we know how to keep people safe. Good PPE works, and good PPE hygiene, eating alone, not letting your guard down, things like that, they work. The demographics of this thing have also evolved. And this is recent data from the NDH showing that if you look at the dark blue bars, that's the overall proportion of cases, whereas the green is the proportion of ICU admissions, and the and the brown is the proportion of deaths. The greatest number of cases are in our young people, that is teenagers to young adults, whereas the vast majority of hospitalizations have occurred in older individuals, middle-aged and later, and the vast majority of deaths have occurred latter in elderly populations. That said, there are deaths that happen in young people, and there are hospitalizations that occur in young people, and there are many older people who do get better. We realize that the mortality numbers coming out of Italy and some of the mortality numbers coming out of New York and our early mortality numbers, comparing them to now, have substantially decreased. And I think that that is likely for a few reasons. I think it reflects a different population at risk with time, but also reflects that we have learned how to care for this thing, care for patients with this. We have so much yet to learn. But also that I think we have learned how to do it in a planful way that's not panicked, that's not chaotic, that instead says, let's bring the best of our medicine to this, do this in a planful way, be safe as we go through. A talk here would be remiss without talking about reinfection. These make the news every time they happen, and there's a couple published cases of patients who've been reinfected. The only way you really can know if a patient's reinfected is to have viral sequencing from both strains of their infection, because patients do have prolonged positive PCRs. When we started this thing, we said patients aren't negative till they have two negative PCRs, and we realized we were keeping people everywhere in the hospital so long And we've learned that PCR positivity after 10 days or 20 days in the severe illness actually isn't the same as infectivity. So this is a case of a patient who was infected in Hong Kong, subsequently actually was tested upon re-entry, had traveled, and actually had a few more, had a repeat test there that revealed 2 genetically distinct strains. There's a few other cases as well that have suggested this, and we need some more time to figure this out. It does not appear that this is a population level problem, but we need some more time to figure out. And we're following very closely along with the CDC with this as well. So I started to think about, and things started to get better at the end of June. July was pretty good, and then things started to peak again, started to ramp up again. For a few reasons. I think people started to make different choices. People started to not be at home anymore, knowing that order had been lifted in June. There was, again, a little more travel. We started to see people get it. Oh, I got it at a family gathering. I got it at a wedding. I got it at a cabin. And so that felt like there was more coming, but now I felt empowered for that steep hill that I know we're continuing to climb up now, because we knew about treatment. And in treatment of the adult patient with symptomatic COVID, there's a few things to identify, but the most important thing is good old supportive care. It is the basics. It is bringing patients in, supporting them, trying not to have other things happen to them while they're in the hospital. It's figuring out what is safe. Can we use, there is a role for high flow nasal cannula that there wasn't earlier. We realized that the intubate early strategy might not be the best. We learned very quickly that these patients have venothromboembolic events, and thus aggressive anticoagulation appears to be helpful. There's some meta-analyses out there working on that now. We learned as well to do the basics around nutrition and supporting patients knowing that they're alone as well. But I think it's good to highlight in this, just so you're aware of the emerging evidence around treatment of this in the adult patients, because you may encounter this. Again, I know it's a pediatric grand rounds, but I think important for this contextual knowledge. The ACT series of trials, this is the ACT 1 trial. I'll highlight Dr. Susan Klein and many others from the University of Minnesota who've worked on this as one of the lead authors. Remdesivir, the ACT 1 trial compared remdesivir versus placebo, remdesivir being an antiviral agent. And this trial showed actually a decrease in the length to recovery of patients receiving oxygen, and better in the patients, actually the flows separate a bit more. In panel C, there's patients receiving oxygen. And so, however, it does not appear to have a mortality benefit. And so that said, it appeared, and so early on there was a decision made to grant, after this trial came out, or actually after the interim analysis of this trial, emergency use authorization was released, and this was given to the states. We all of a sudden had to figure out then, how do we allocate a scarce resource in our system? And thanks to people like Dr. Jennifer Needle, Dr. Sarah Kessler, and our colleagues in the pharmacy, we've set up a triage system in our system where students working and rotating the Systems Operations Center, who have been pulled out of the clinical space, work together with many of us who are trying to figure out how to triage this and set up a system so that it was actually, so that patients who met criteria received this medication in a standard way in case it was scarce. Lucky it's never been scarce, and we've been able to change that process recently. Patients continue to come. There's leaves on the trees. Now it's summer. Another picture of juxtaposing an ambulance there with hearts walking out of my shift one day. The evidence continues to evolve, though, and if there's one thing that I think we need to highlight in care for COVID patients, it's that following the science and following really high quality science is really important. All of us are now familiar with this preprint site that's releasing information that's showing that potentially this says, well, maybe remdesivir is less helpful than we think. Again, not demonstrating mortality benefit, but a very substantially different done study again, no mortality benefit, maybe a suggestion of improvement in time to recovery, but it's fundamentally differently designed trial compared to the ACT trial. This is looking in that trial, again, showing maybe a suggestion of benefit, although those confidence intervals cross 1, knowing that if there is a benefit here, it's probably in the slightly less ill patients who are still requiring oxygen. I think one of the biggest surprises for me, though, here was a Thursday when the press release for this study, the recovery trial that was done in the UK, was released. This was when it came out and said there is a mortality benefit for dexamethasone in patients who are hypoxemic with COVID. That was a surprise, and I've never made a practice decision based on a press release before. What we had at that point was the press release and the protocols of the trial, and we dug into those and said, yeah, it looks like there's good science here. At that point, we made the decision within a few days to start using dexamethasone because, again, in patients, if we look at mortality here, generally the patients who benefited the most were patients who were receiving supplemental oxygen compared to those who weren't. We decided to start using dexamethasone. There's a lot of press around plasma. We had an expanded access program, from Mayo, where we were giving convalescent plasma. Incredible effort by our colleagues in the blood bank to screen every patient for convalescent plasma. And this is a cautionary tale, because this is released from the FDA, but the FDA there is releasing relative risk reductions instead of absolute risk reductions, and comparing here high titer versus low titer patients. They compared patients who got high units that had high titers versus units that had low titers. There's no placebo, and it was a little bit of statistical gymnastics here. The decision after this, when this was released, was that they granted an emergency use authorization for this as well. But in contrast to remdesivir here, now we learn that not all EUAs are created the same. Here, this actually said the convalescent plasma should not be considered a new standard of care for the treatment of patients with COVID. And in fact, we said in our system, we think it's our moral obligation to participate in a study that's actually going to be starting very soon, rather than continuing to do something that might not be evidence-based. There's a lot of promise of tocilizumab early as well from observational work. Subsequent randomized trials of tocilizumab have also failed to demonstrate a large-scale benefit. Knowing tocilizumab is a medication, obviously, that tries to decrease some of that so-called cytokine storm. I want to emphasize, though, this is scary, and we can keep our people safe in general. Yes, people do get COVID. People get COVID at home. People get COVID going to restaurants and bars. Some people, there are exposures at work, and we take every one of those very, very, very seriously. But if you compare some of the positivity rates from Montefiore, for example, in New York, compared with Hennepin County Medical Center here, showing that as your community prevalence is very high, your healthcare worker prevalence will be high, and the same goes if it's lower. But knowing that we can actually have patients or have our healthcare workers be quite safe, and we've demonstrated that in our system, that our healthcare workers in general are quite safe. One of the last things I want to talk about here is how long patients are positive. I think this has been one of the more confusing things for people. We put that COVID recovered status into EPIC, and our infection prevention colleagues are working on that. And why did we have to do that? It's because patients, if you look at the left screens the left side of your screen, patients have positive throat and nasopharyngeal swabs for days and days and days, if not weeks. That said, in general, most of these patients have, with serial viral culture, the studies have been done. No one's been able to culture it really past day 8, and so day 10 for the mildly ill patient, or day 20 for the patient with moderate to severe illness. There's been no demonstrated cases of transmission after that. So while a patient may have a positive PCR for 3, 4, 5 weeks, they are not infectious for that long. There's cognitive dissonance there to say don't trust that test, but that is just viral nucleic acid product being shed, not active viral replication that is associated with infectivity. So I'm excited to answer a few questions here, but I think I have just a couple last things to say. This is hard work. And I'm incredibly grateful to all of the people who've done it, who've been there day in and day out working on this. And I'm incredibly grateful to those of us who have been supported in doing this work. And also we have to look for the wisdom around us. And this is my wife, Janelle, and I, and she said, Andrew, we're taking a day off and we're going kayaking. And we did. And I felt like I could love the world a little more again that day. I'm getting up, going down the St. Croix River. We have to celebrate some of the wins. This is Rick Huggins. You may have seen this story on the news. Rick was very ill, hospitalized for over a month on a ventilator. Called people at Bethesda and said, I'm feeling better. I want to ride my bike. He did a 60-mile bike ride and came to thank everybody. And we stood outside on this beautiful summer day and celebrated him getting better. And he said, thank you, thank you, thank you. His dear wife came as well. We have to celebrate those things while we mourn those we've lost. So I'll end as I turn to questions to thanking all of you. This is one of my favorite signs. You're from a Cub Scout troop, that you're a straight up gift to humanity, and all of you are. Thank you for the work that you do. Thank you for caring for our community's children, knowing this is a tough time for so many. And I'm glad to take some questions. So.
Thank you so much, Andrew. That was really inspiring. And I remember seeing you that day at the state capitol at the protests, and you had taken time to invest in something so important and literally went from being at that protest to going to make decisions about remdesivir. And I just remember being so impressed with the work that you're doing. So thank you for the work that you've done and for being a leader in our department and our medical school and our community.
Okay. Thank you.
So we've got some questions from Dr. Andy Rzepka, who is a community pediatrician. He has some questions about cleaning practices. So he talks about learning as you go in the life of COVID on surfaces.
Yeah. So the question is, where do people get COVID? And certainly you can you can find virus on surfaces. And as we all know, there's a lot of there was a lot of press early on about, oh my gosh, how much COVID is on the playground. And certainly that probably happens some. By far, however, the greatest, the most significant transmission is person to person when they're together for longer than 15 minutes and without PPE. In healthcare, most transmission in healthcare settings among healthcare workers, by the way, is healthcare worker to healthcare worker. It's not patient to healthcare worker. And that probably happens. People let their guard down, they sit down and do the things. We break bread together, we have lunch, right? We eat together. It's kind of what we do. And knowing that's not a safe thing as much anymore. There are reports, and some of this has been from Europe. Some of the has shown that there's some really elaborate contact tracing that has come from services. My personal feeling, and this is my personal feeling, is that if we focused on masks, hand washing, and distance, and not doing elective things outside our homes as much as possible, we'd be a lot better investing in that than UV decontamination for your door handles. I don't know, but I think that the risk is much higher with person-to-person contact.
This next one, I don't know if it's philosophical or political commentary, but Dr. Rzepka also asked, what do you think of CNN's Wolf Blitzer giving an epidemiology lecture in 30 seconds?
So I stopped trying to watch the news very much, but I think I will say that an educated populace is a really important thing here, because the conversations, I think, around how do we transmission of disease, cases, mortality, statistics. What is evidence-based medicine? An educated populace around those things, I think, is really important. And so we have an obligation, I think, as those working to communicate to the public, to use our voice. I think Dr. Crone has done a really nice work in highlighting some of that from our department. And so I think that we have a moral obligation to help not, there's disinformation that we should not allow to stand. And we need to call out, or respectfully and appropriately, but we need to call out when disinformation is being spread from members of the community. And again, we don't do that. We do that with grace and with science. But I think that we have an obligation to do so.
The kind of another, you alluded a little bit to getting some of your own information as a healthcare professional from a press release at points during this pandemic. Do you have any tips for keeping up on the literature?
Yeah.
Where are you turning?
Yeah, so it's I think there's a couple things. One is, I think this highlights the need for a partnership between an academic and a community practice, that we have learned so much in having people cull the literature. The university has an evidence-based medicine group that they put together early on to help us with that, and said, I need help understanding what's the evidence around this. And so the dexamethasone question, we went to them and said, can you help us make this decision? And so rather than just deciding on a press release, we dug into the protocol and said, if this is the finding and this is the protocol, it seems like there's a substantial benefit, or a moderate benefit. You know, we also had to remember and keep our principles there around things like hydroxychloroquine and azithromycin. There was actually a hydroxychloroquine and azithromycin dot phrase in our system for a couple of weeks that we realized which was quite striking. And we said, no, stop that. There's no evidence about that. That's case reports and tweeting from non-healthcare professionals. So I actually, I think there's some really nice protocol sites out there. The Massachusetts General Hospital is one. We have protocols in our system that are pretty well kept up to date. I think the other thing is that most of the major medical journals, JAMA and New England Journal, Lancet, BMJ, most of them are keeping up pretty nicely and making all this information free. The other thing that's become prime reading is the MMWR and JAMA each week. I think we should have to pay attention to that. And there's been some talk about the politicalization of that, which we have to speak against. But I think reading that is really important. That's where we understand some of these prevalent studies.
Great, thank you. Can you comment a little bit on ICU capacity within our system, especially as we're hearing about capacity problems in other states?
Yeah, so hospital system capacity is a complex equation that has physical beds, staffed beds, and then the inputs of sick patients and planned admissions. I think we're going to be okay in our system. I really do. The goal is obviously to keep the system going, doing the work that we need to do around elective cases and invasive procedures and things like that. Bone marrow transplants, things like that, we need to keep going. And so I think that we're better than other states around us just because we have better ICU capacity in general. Northern Minnesota has been hurting recently. And so there is some limited capacity up there. It's unclear to me in Northern Minnesota, though, is the limited capacity, how much is that due to COVID and how much is that due just to sick patients? So I think we're going to be okay. And I think we're going to be okay. It's maybe hard, but I think we're, the main thing is the state and Metro have a really great working relationship among all of the health systems to try to decide where do we move patients around, and if one system's full, there's a way that's been put in place to move them around. Yeah.
Thank you. I think we've got time for a couple more. This one comes from Chet Whitley, who's wondering about serology testing and if there's any benefit to repeating it. So the example is a patient who had a significant respiratory illness in March, several weeks later tested negative with serology, you know, do you test them again? And, you know, what
Yeah.
does it mean even if you have a positive antibody
A
titer?
really good question. My most honest answer to that is that we don't know. I think that knowing that something like 40% of infections are asymptomatic, knowing that's probably not equal across ages, but did the patient, what did they have just below the titer level that's called a positive there? It's possible. I think that the question is, so say you get a positive, does that mean the patient's immune from future infection? We don't know that, maybe-ish. But we don't know that answer, knowing that it's a viral thing, and thus T-cell mediated immunity is really important. And so the way I'm explaining it is, it in the subacute setting, it may help put a picture together when you don't have a positive PCR, but you have an ill patient. For this patient, it would be, I would say, a matter of curiosity that I wouldn't make future treatment or lifestyle decisions based on. So it's hard. I don't think we know. You know, I got my antibodies checked recently and they were negative. I don't know what that means. It's hard. I think we will know more as time comes on, and we will know more as we have a longer duration of testing those.
Thank you.
Yeah.
Marissa Hendrickson said, thanks for this beautiful and inspiring talk. Are there any healthcare providers or other frontline workers in our healthcare system who've died from COVID that we should be recognizing?
Yeah, so I'll be respectful for privacy, but to know that there are people who've gotten ill, and many people have had family members with this, and we all have seen some of the amazing stories of the trainee at Hennepin who was on ECMO and walked out of that hospital. I think that yes, this is something that needs to be done, and I think we as a system, we have been incredibly fortunate that people have, in general, recovered. But the thing I do want to emphasize is that many of the people who've had it continue to have this so-called long COVID. It's not chronic, but it's long COVID syndrome, where they're really struggling and trying to get back to their baseline, knowing that many people continue to not be back to their baseline weeks and weeks after. But I think that's an important question to continue to address as we go through this, Marissa, and knowing there, but for the grace of God go I every day.
Wonderful, yeah. Thank you. I suspect that we could talk with you for another full hour, just peppering you with questions, and maybe we'll have you come back in the spring and share an update. But we just want to thank you for all of your incredible work, and keep sharing your knowledge, and we'll try to keep supporting our adult colleagues in whatever way we can from the PEDS side.
Perfect. All right. Thanks, everybody.
Have a great day.